So what is a STEMI? A STEMI is an elevation of the ST segment of at least a millimeter, and here is the key, in at least 2 contiguous leads. Contiguous means 2 leads in the same territory, okay? 2 leads in the same territory. The exception to that is V2 to V3. The reason for that is because lots of people have a little bit of ST elevation in V2 and V3 all the time. It's called early repolarization. You don't have to worry about that. Okay? There you need 2 millimeters of elevation and preferably 2.5. Okay? If the patient has a new left bundle branch block and you are not a cardiologist, you won't be able to read whether or not they have ST elevation or not because left bundle branch block screws things up. It turns out there's actually a way to read through the left bundle branch block called the Sgarbossa criteria for anybody who wants to know. It's SGARBOSSA. All right, so all this is saying in all of these different things is that you have elevation in the appropriate territory, okay? So a STEMI in some territory means you have an infarction in that territory, okay? There are a couple of notable exceptions. If you have left main disease, you're probably going to have ST depression everywhere, and AVR is going to have ST elevation, real ST elevation, okay? That's a very, very high-risk finding. Posterior MI, none of the leads on a standard EKG look at the back of the heart. They're all designed to look at the front and the side. Okay? They do not look at the back of the heart. So to figure that out, what you have to figure out is that they have an inferior MI, and then you've got to realize that there's too much R wave and too much ST depression in V2. Okay? All right, very good. So right here, they're showing you some EKGs. This should be fairly obvious. With most heart attacks, the ST depression should have reciprocal ST depression. This is another key differentiator between a heart attack and pericarditis. Pericarditis does not have reciprocal ST depression. Only heart attacks do. What you're seeing is the change on one side being reflected in the opposite change on the other side. Okay? So here in the septal territory, V1 and V2, we see this massive ST elevation. Goes on to V3. Now we're in the anterior territory, right? V4, still anterior territory, still got a couple of millimeters of ST elevation. It's gone by V5 and V6 because that's the lateral territory, right? The opposite of anterior is inferior in the heart, right? So it's no surprise that when we look at the inferior leads, we have this ST depression in the inferior leads. So we would call this an anteroseptal myocardial infarction. Anytime you have more than one territory, it should never be more than 2 territories. You just name the territories that go together. So if it was V3, V4, V5, and V6 that had the ST elevation, what would the name be? Anterolateral MI. There you go. You got it. If it's 2, 3, and AVF and V5 and V6, what's the name of that heart attack? Inferolateral. You got it. See, it's just that easy. You guys are already pros. All right. So here is another EKG. This is designed to show you a left main heart attack. Note that there is ST depression everywhere. Inferior territory, check. High lateral, check. Lateral, check. Anterior, check. Everything has ischemic changes, and here's the key, when you go to look at AVR in this one, all the way up. Call the cath lab. You got a problem. Okay?